Hello.
Yes. Good to see you.
Good to see you too. How are you?
I'm fine. We are waiting, and we are going to start a live case, but we will start case presentation first. Dr.
Thank
Lee?
you.
Yes, I'll do start case presentation. 59 years old male was visited for the increased size of a known serous cystadenoma on image follow. From 2010, 2.2 centimeter size serous cystadenoma was found and in the tail of the pancreas. And during the follow-up on 2010 September 6, the MRI image showed the increased size of the macro and microcystic serous cystadenoma up to 3.5 centimeter. November 18, 2020, EUS-guided fluid aspiration and collapsing was done for the two large cysts of the mass with the needle, and the first session of EUS-RFA was done with a 10 millimeter RFA probe under 15 watt 6 times line operation. As you see the initial image, the image shows the increased size of the region. Today, we will do schedule the second time of EUS-RFA. Professor Dong Wan SEO will do the procedure.
Thank you, Dr. Lee. This is the EUS image. Can you see the EUS image now?
Not yet.
Not yet. We will share the EUS screen. Today, we are going to do the EUS guided RFA for serous cystic neoplasm. It is generally believed that serous cystadenoma don't need to touch because it is mostly benign. More than 99% of the cases are benign. Malignant cases are very rare. So recommend just follow. But in this case, over 10-year follow-up, the cyst size showed the increase, and then the patient became a little bit anxious. If surgery is the only option, it's better to follow this case, not to touch. But EUS-guided RFA is not like surgery. You do not need to resect the pancreas. So we are under study doing EUS-guided RFA evaluation of serous cystic neoplasm. Hello, can you see the EUS image now?
Yes, we can.
Yes.
Yeah, yes. This is pancreas. I am tracing the pancreas body with linear scope. While I'm rotating my scope, you can see the serous cystic lesion. You can see the serous cystic lesion here. From here to here, it became large, more than 4 cm. And we already did one time of ablation, so the internal structure is a little different from its native view. We can see some smudged septal wall because of previous RFA. By B-mode image, it is difficult to differentiate which area is ablated, which area is still viable. So we are going to use contrast enhanced EUS to check the viable portion. If there is viable area, we will repeat the second session of RFA. Contrast.
So, Dong Wan, is there a size limitation for the RFA?
This is for palliation of serous cystic neoplasm. So even though it is large, we are not trying to eradicate the tumor completely. So it can be applied any size. Destroy the internal part and make it collapse into smaller size, not to cause any mass effect. Can you see the harmonic image now?
Yes.
Left side is B mode, right side is harmonic image. We are going to inject sonage with contrast and see which area is showing enhancement. Enhancement means there is viable microvessel. That area needs to be ablated. Okay, inject. Now we are injecting sonage on this. To see the enhancing area, we need to use on the right side. We need to see this area. Now the time is 15 minutes. But it starts
And we're
to show
beginning to
some
see the
contrast
contrast.
enhancement. Yeah, these areas are ablated completely, but there are some remaining vessel on this side, and also this area is still viable. And according to, I think this area also, this is marginal area, needs to be ablated again. This is still viable portion.
So the
BMO
post-RSA effect is quite nice. So the
Yes, you
center
can
is
see it.
necrosis and with no
Ablated,
contrast.
yes, yes, yes. So we are going to do ablate this area under contrast lens EUS guidance. And today I'm going to use EUS-RFA needle. This EUS-RFA needle has this handle and also electrode. It is, I'm not sure whether the camera can zoom in. This area is just exposed area electrode. It's 1 cm. So 1 cm electrode to this large lesion, we need multiple ablation if you do just the spot ablation. So to reduce the time, I'm going to use a line ablation while drawing the electrode, and we do continuous ablation. And this is the generator, and this is irrigation, water pump. While doing RFA, the heat is generated a lot around the electrode. If you do not cool it down, then tissue charring can happen. If the tissue shows charring phenomenon, then further delivery of energy is impossible because of a rapid increase of impedance. So we are going to use a cold saline through this line to cool down the electrode tip.
So does the RFA probe comes in different sizes? So
Excuse me?
does it come with different size? Because I remember there is a 1 centimeter, there is a 1.5, and there is a 2 centimeter probe that we can choose from.
Yeah, there is different size of electrode. But we tested the different size electrode, and we did the in vivo and animal studies. But I want consistent results. If we use longer length electrode, then I want to check the tip of the electrode sheet, and then I'm going to. If you use a 1 cm electrode, can create consistent like ellipsoid ablation. Length is about 1.2 to 1.4 cm, and the diameter is about 8 millimeter. But when it goes to 2 cm electrode, the proximal part and the distal tip can burn first. And then in the middle part is less ablated. So I want to see the consistent result. That's why I am using 1 cm electrode instead of 2 cm, 3 cm electrode. It is possible to use that, but I think my electrode is now outside, and I am puncturing the viable part. Can you see the
very nice.
electrode check? Yeah, this is electrode. So I'm going to apply power here on the EUS, direct EUS view. I applied the power, then I think I can see. But this area is already ablated area, sorry. I think I need to stop here.
So usually, how do you decide on the power? So how many watts, or do you depend on the impedance?
This type of large lesion, I use 50 watts.
50 watts.
If the lesion is small, then I use 30 watts.
Okay.
Because the smaller lesion, if you ablate with big power, then there can be some complication issues. Now I apply the power, we can see echogenic bubble formation from the tumor here.
So Dong Wan, hi.
Yes.
Yeah, as a non-EUS endoscopist, may I ask some simple question? For example, under EUS, how do you define the endpoint of this radio frequency ablation?
That's a good question, very important question. Endpoint, you mean the ablation margin or the volume reduction or complete resolution? Which one? The margin-wise, we cannot ablate the far distal margin. I think it is risky because if we ablate the margin with the large power, then normal pancreatic parenchyma can be injured. So the subsequent pancreatitis is the risk factor.
And Dong Wan, do you actually repeat the contrast EUS after the ablation to see the area whether there's still some contrast enhancement or already operated to be one of the endpoint?
After RFA, I already injected contrast. As you see here, you can see some contrast material. I am using Sonazoid. Sonazoid acts more than 5 minutes, 10 minutes. So it is good contrast agent for this type of ablation. If you use Sonoview, the action time is short. So generally it disappears soon.
Okay.
So I'm using Sonazoid, but just one time. Yes, if you inject multiple times, then we can get a more clear view, but it's expensive.
So usually how far apart are the two RFA sessions? So for example, after this session, how...
Generally 3-4 days.
3 or 4 days.
After first ablation, next day and 1 day, 2 days later, sometimes the patient develops fever or pain. So we need to observe it. We did not experience any severe pain or persistent fever. Although it is transient, there is some phenomena. So after resolution of that, we plan the second session. In this case, last week this patient received 6 days ago received the first RFA. Now we are doing second time of RFA. Here we can see some blood flow inside. So I'm going to try to ablate this blood flow by RFA. Here it is. If there is viable vessel, then it will supply blood to the tumor, and the tumor will grow again. So better to ablate it. And when you look at this area, there is but the limitation is contrast enhanced harmonic imaging. Gives very poor resolution. So it is the limitation of using this image. But you can see roughly which area has viable vessel, microvessel. I'm going to try to ablate this area again. As you see here, echogenic bubble is formated and inside is ablated. I think the marginal area may have some viable tissue, but most of the lesion in the center are ablated now. So I think it's better to stop here and receive some questions or comments.
So what is the usual post-procedural care for these patients? So is there any specific thing you would monitor, for example, taking blood for amylase after the procedure, or you just observe for pain?
Yes, routinely we check pain and the blood test to check the amylase lipase, whether there is any possible complication. And then this is inward procedure. Generally discharge the patient 3-4 days later. And with the follow-up, initially we did 1 month follow-up with CT scan or MRI. So nowadays we do follow-up 6 months later. So I think because it takes time to resolve the cyst, ablated area to be observed.
So are there other indications for this EUS-guided RFA procedure?
We are trying to expand the indications now. This is one of the areas, Serous cystadenoma with a mass effect. can be targeted by RFA. Another one is neuroendocrine tumor or insulinoma that are very good target. And also solid pseudocortical neoplasm can be a good target. And also we are adding RFA for pancreatic cancer. The patient receives chemotherapy and we are adding RFA to increase the chemo effect and also to add tumor direct ablation effect. We are under study now, right now. We don't know how the long-term follow-up results will show, but we are hoping that combination therapy can increase the effect and can prolong the survival benefit of the patient, can prolong the survival of the patient.
So, Dong Wan, thank you so much for this very nice demonstration. I know that you would be continuing this procedure for a while.
Yes.
So we will be okay. So there's one more last question, quick one. So for RFA from the floor actually. So what is the rate of complication like pancreatitis?
It depends on how you do the procedure. If you are doing overly ambitiously, then there is complication. But in our series, the complication, including mild pancreatitis and transient fever, is less than 10%. It all depends on how, as I mentioned, how you do the procedure. If you see the surgical literature, surgeons are doing very aggressive RFA during intraoperative periods. For pancreatic cancer, unresectable pancreatic cancer, they did intraop RFA. Then we can see some fatal cases because of late bleeding from main portal vein or surrounding tumor surrounding vessel. So it is important not to do overly ambitiously. We need to keep the safety margin.
Okay, thank you, Dong Wan, for
Thank you.
this very nice tip. Professor Dong Wan So is a professor from Department of Gastroenterology, Asan Medical Center from South Korea. Thank you so much.
Thank you,
So-
Dong Wan.
Thank you very much.
Thank you.
Bye-bye.
So, bye bye.